Good morning, everyone. Today, in this continuation of the FRCS training program, we are going to discuss prostate cancer. Many thanks for the trainee who has volunteered to record this program so that it can be used as a good revision tool. Today's examiner is Anish. Anish, the floor is yours.
Thank you so much, Mr. Dhanasekaran. We have planned this session in two parts. In the first part, we will discuss the initial clinical presentation, something regarding the role of screening in prostate cancer, and moving onwards, we'll discuss on the active surveillance as well. In the part two, we will discuss more on the treatment options and also on the metastatic prostate cancer. We will start now. So in the exam scenario, what happens is you will be guided to one of the tables, and the examiner will tell you what the table is, what topic is going to be discussed in the table, and then it moves afterwards. So you are in the prostate cancer table. You have a 64-year-old gentleman referred by the GP for a PSA of 5.4. The referral was in a 2-week wait referral. So how would you like to proceed from here?
I will see this patient in my 2-week cancer clinic. I will take a proper history, focus examination, and did some investigations. So I will concentrate on first why this patient had the PSA blood test. Is there any symptoms like urinary tract symptom, erectile dysfunction, which triggered the PSA blood test, or it was just a screening? After that, I will take a history from the patient asking about any LUTs, voiding or storage LUTs. I will exclude any cause for falsely elevated PSA, like a recent urinary tract infection, instrumentation, or sexual intercourse. I will ask about any risk factor in this patient, like the age, the ethnicity, and any positive family history. And I will ask about any symptoms of advanced disease, like bone pain or new onset neurological symptoms. I will ask about the baseline erectile function and bowel function in this patient, and then I will go to the past medical history about his comorbidities and use of medication like anticoagulant, any previous surgery or radiotherapy, and then I'll ask about his social history as well. Following that, I will do examination in the presence of chaperone with the patient consent, and general examination looking for any pallor, feature of advanced disease. And then I will concentrate on abdominal examination, look for any palpable bladder. I'll examine the genitalia, and then I will do a DRE, looking into the consistency of the prostate, the nodules. I will assess the rectal tone as well, and looking for any lower limb edema, and I may do a focused neurological examination if there is symptoms suggestive of that. I will do a urine dipstick for the patient on arrival to exclude any infection. And then, since his PSA is outside the age expected for his age, his PSA shouldn't exceed 4.5. So my recommendation is to have another PSA. I will have a discussion with the patient about the pros and cons of PSA testing. And then my recommendation is to have another PSA testing. And then if it is still elevated, then we'll go ahead with further investigation.
That's perfect. That's a really good start. And you have covered almost all the points that I have written. Very good.
Thank you.
Moving forward, do you know about the guidance that GPs has for the prostate cancer, suspected prostate cancer referral?
Yeah, so I think this is in accordance with the NICE guideline, early detection of cancer. So any patient with high PSA outside the age-specific PSA or abnormal digital rectal examination, or both of them, need to be referred urgently. When the PSA is less than 10, then 2 PSA reading is required before referral. The GP need to make sure that there is no recent or active urinary tract infection which causes false elevation of the PSA.
All right. So you said focusing on two things. You said that you will ask for the family history of prostate cancer. So what's the importance of family history of prostate cancer? or what is hereditary cancer of prostate?
Yeah, about 5 to 10% of all prostate cancer is familial. And when there is one first degree relative with a history of prostate cancer, if it is the father, this will increase the chance of having prostate cancer by 2.5 folds. If he is the brother, it will increase it by 3.5 fold. If someone have two first degree relative affected, then the risk is a 5-fold increase. Certain people with, especially with the BRCA2 BRCA2 chromosome abnormality, those patients are more liable for early and aggressive form of prostate cancer.
Amazing. So what's the half-life of PSA?
So the half-life of PSA is about 2 to 3 days.
All right. And according to the UK data, what is the lifetime risk of a man acquiring a prostate cancer?
This would depend on the ethnicity as well. So for a white man, the risk is 1 in 8 to have a prostate cancer in his time life. For people from the Afro-Caribbean background, it is 1 in 4. For the Asian people, it's lower than this, about 1 in 12.
Very good. Do you know about the evidence of that figures? Which UK study said that figures?
No, unfortunately, I'm not sure.
No problem at all. So it is called as a process study in the UK, which gave all those amazing exact figures regarding the ethnicity. But well done. That's exact numbers. So you said that you will do a DRE, and you said that you will look for specific things. One of the questions that can be asked is, does DRE affect the PSA level? Can it increase the PSA level?
Yeah, in my practice, I prefer to do the DRE after we take a blood for PSA. However, there are some studies show that DRE would cause only very minimal elevation of the PSA, around 0.24, which is not clinically significant.
That's perfect. And regarding the, you absolutely were spot on saying that this was this man's PSA is 5.4, and it is more than the age-specific range. Is there any studies that has addressed the age-specific preference ranges?
Yeah, we have this evidence from Osterling study, which put an age reference for people below 50, it should be less than 2.5. People below 60, it should be less than 3. People below 70, it should be less than 4.5. And then for people above 70, it's usually 6.5.
Perfect. Good numbers. And moving forward, if the patient is in front of you, he had his repeated PSA, and his repeat PSA is 5.6. So he's asking, can you predict his risk of having a prostate cancer based on this PSA, ethnicity, his age? Do you have any tools that will help you to tell the patient what risk he has of harboring a prostate cancer?
Yes, we have some tools which predict the risk of prostate cancer. I am aware of the SRPC, the SWOP risk calculator, which include the patient age, family history, the PSA, and ethnicity, and give him an estimated risk. Perfect,
yeah. So, and there is, as you know, there is one more. It's called the PCPT calculator, but you're right, yeah, ERSPC calculator as well. Amazing. Yeah, so, regarding, because we are going to one of the most controversial fields in the prostate cancer, do you think screening for prostate cancer is justified, and what is the UK stand on the screening of prostate cancer, screening for prostate cancer?
Yeah, we have the typical criteria for screening, which is the Wilson and Younger 1968 WHO criteria, which contain 10 criteria for screening of disease. And actually, prostate cancer doesn't fit all these criteria. There are controversy about any benefit of screening because we have conflicting results from previous study. We have the PCLO study from USA, which didn't show any benefit for early screening and detection of prostate cancer. However, this study was followed by significant contamination, more than 50%. The other study is SRPC, which is the European randomized study for screening of prostate cancer, which showed a relative risk reduction of cancer death about 19%, which is quite significant. And when the study was extended more than 15 years, the benefit was even more. So there is a positive evidence from this study. There is also, I'm aware of the CAP randomized study, which was done recently, which didn't show again any benefit for early screening. So my stand, or the stand of the UK, in the UK there is a prostate cancer risk management protocol, which offer the PSA for men after the age of 50. And the NICE guideline recommend to do a PSA blood test for any patient who presented with lower urinary tract symptoms, erectile dysfunction, or visible hematuria, which will be like a selective screening on the high-risk people rather than general population screening.
Well done, spot on. All the studies that are mentioned are absolutely spot on. Well done. So one of the questions is whether we can prevent prostate cancer. Are there any studies addressing this one?
So there is a study which is called the Prostate Cancer Prevention Trial, PCPT, which included, I think it is about 18,000 men with PSA more than 3, and then the patient were divided into two groups, or some of the half of the patient given placebo, the other half given finasteride 5 milligram. At any time during the study, if there is a high PSA, increase in the PSA, or abnormal DRE, the patient will have a biopsy, and then all the patients will have a biopsy by the end of the study. And they found that finasteride group, they have a reduction in the risk of prostate cancer by about 24.8%.
Perfect, amazing. So coming to this patient, his PSA is, the first PSA is 5.4, his second PSA is 5.6, and you did a DRE, which is normal. So how are you going to proceed from here?
I'll counsel this patient about the risk of having prostate cancer, since his two reading of PSA outside the expected reference for his age. I will advise the patient to have an urgent multiparametric MRI of the prostate, looking for any suspicious focus inside the prostate. And then if the MRI confirm the suspicion, then we need to go ahead with the prostate biopsy.
All right, perfect. So what do you mean by multiparametric MRI scan?
So we are adding some functional parameters to the MRI scan in order to increase the sensitivity and specificity. So in addition to the T2 weighted images, which mainly give us some anatomical details, the MRI also, in the MRI we can do the diffusion weighted imaging and dynamic contrast enhancement, which will increase the sensitivity and specificity of MRI scan. And the third parameter also, which is not commonly performed, is the magnetic spectroscopy as well. Perfect.
And do we have any evidence to say that MRI can improve the diagnostic accuracy of the biopsies?
Yes, the evidence mainly came from the PROMISE trial 2017 by Hashim Ahmed, which showed that the MRI have a very good sensitivity and specificity with a negative predictive value of around 90%. So it can avoid biopsies in about 28% of the patient. It will detect more clinically significant prostate cancer, and it will avoid clinically non-significant prostate cancer.
All right. And is there any other study? Have you heard about the precision trial?
Yeah, so the precision trial is similar and also give a similar support to the use of a pre-biopsy MRI, which detects more clinically significant prostate cancer than compared to transrectal ultrasound.
Well done. So this patient had his MRI scan. And the MRI scan is reported as Pyrites 4 lesion in the left peripheral zone. His prostate volume is 40 cc. That brings to a PSA density of 0.13. And the report is like, if any cancer is identified, it will be T2 and 0 M0. So moving through all these parameters, so what do you mean by Pyrites?
So PARAD is a standard protocol for reporting MRI of the prostate. It is the prostate imaging report and data system. We are using the version 2.1, which is standardized the reporting of prostate MRI for the purpose of detection of prostate cancer. So it consists of 5 grade, PIRAD 1 and 2, usually regarded as benign with low possibility of detecting clinically significant prostate cancer. PIRAD 3 is PIRAD 3 is in the gray zone, and then we have PIRAD 4 and 5 with high risk of having clinically significant prostate cancer. So I'm with PIRAD 4. I will definitely recommend to go ahead with a prostate biopsy.
Okay, so what is the NICE guideline stand on biopsy based on the PIRAD scoring?
So the NICE guideline 2019, they rely more on the Likert scales rather than the PIRAD, which is very similar to the PIRAD, but includes some clinical information like the PSA density, the family history, the DRE, and the previous biopsy. So it's a little bit more objective than PIRAD. So the NICE guideline recommend to offer any patient with PIRAD 3, with Likert 3 or above a prostate biopsy.
Perfect, well done. And the report also says about the PSA density. Is there any importance of PSA density, and how do you calculate PSA density?
Yeah, so the PSA density is calculated by dividing the PSA on the prostate volume. We can get the prostate volume by measuring, by multiplying the height by weight, by the height, by length, by width, and then multiply all this by 0.52 or divide it on 2, which is the ellipsoid volume formula. And when we get to the size of the prostate in mil or cubic centimeter, we can divide the PSA over the prostate volume. The PSA density should be less than 0.15 microgram per liter for the benign disease. But if it is more than 0.15, this increases the risk of detection of prostate cancer. I will use the PSA density, especially when we have something like a PIRAD 3 lesion, and we are not quite sure. So if the PSA density is more than 0.15, this increases the chance of detection of clinically significant prostate cancer. And using the PSA density in the PIRAD 3 lesion, it can avoid biopsy in about 45% of the patient. However, it may miss 6% of a clinically significant prostate cancer.
Well done, well done. So moving forward, for this patient who is 64-year-old, normal DRE, PSA 5.4, no comorbidities, fit and well, whose MRI scan shows Pyrites 4 lesion in the left peripheral zone, how are you going to see this patient, and what will be your plan for him?
So I will see the patient in the clinic. I inform him about the result of his MRI scan, which raises suspicion of clinically significant prostate cancer, and I would recommend to do a prostate biopsy. In my practice, we are doing the LITP biopsy. So I will counsel the patient about the technique of the procedure, the risk, benefit, and any other alternative. I will support my counseling with the PAUS leaflet for the procedure. I will explain to him that this procedure will be done under local anesthesia, and the possible complication include hematuria, bleeding from the rectum, and hematospermia, which may contain up to 10 days after the procedure. There is a very low risk of infection with the LITP biopsy, less than 0.2. However, in my practice, I will give the patient a single oral dose of ciprofloxacin 45 to 60 minutes before the procedure. There is a low risk of urinary retention, less than 5%, and there may be some temporary erectile dysfunction after the procedure, depending on how extensive the biopsies. and there is a low possibility of repeating the biopsy again if the biopsy is inconclusive. So if the patient is happy with that, I will review the patient medication, and if there is no contraindication, I'll book him for an urgent LITP biopsy, aiming for a targeted and systemic biopsy.
Very good, very good. So, you said about the antibiotic prophylaxis, and you said that in your trust you give ciprofloxacin. Nothing wrong in that, because it all depends on the local policies. But I hope, you'll be aware that in EAU 2021, they are recommending against fluoroquinolones. So when you say ciprofloxacin, just like you said, you had to say that it is based on your local antibiotic policy.
Yeah, definitely.
So, yeah, perfect. So before moving on to the biopsy of this patient, what will be your approach if a prostate biopsy shows high-grade PIN?
So, high-grade PIN is regarded by some study as a precursor for the prostate cancer, depend on the age incidence, and usually it detected about 10 years prior to any prostate cancer. And some of the patients with the biopsies, the other people, they don't think there is any significance for the high-grade PIN, but in accordance with the EAU and NICE guideline, if the patient has a multifocal high-grade PIN, then there is a higher chance of detecting the prostate cancer in subsequent biopsy, about 20 to 40% the chance. However, there is no clear recommendation from the guidelines when to repeat the biopsy again and which form of biopsy, whether it is systemic or targeted.
Well done. So, are we all right to move forward?
Yes, please. Yeah.
Yeah, thank you. So, these patients, we have the MRI scan, we have the PSA. Now we are going to discuss it in the MDT, and the pathologist tells you that the report of the LATP biopsy is showing the number of scores were 24 plus 4 targeted, and the 4 out of 28 scores are positive for Gleason 3+3, grade group 1, with less than 50% involvement of the cores.
Yeah.
Okay, so what I mean, we know about the Gleason scoring. What is this grade grouping?
So the grade grouping is suggested by the International Society of Urological Pathologists. It divides the Gleason score into groups. So group 1 is a Gleason 63 plus 3. Group 2 is a Gleason 7, 3 plus 4. Group 3 is a Gleason 7, 4 plus 3. Group 4 is 4 plus 4, and group 5 is any Gleason 9 or 10.
Okay, perfect. And so you are leading the MDT. So what will be your recommendation for this patient?
So for this patient, I want to know from the histology report the exact Gleason score for the patient, the percentage, the number of cores involved, any perineural invasion as well, if there is any tertiary pattern as well. And then we will review with my colleague in the MDT, I'll review the histology and the MRI scan. And then we will risk categorize this patient according to the NICE guideline risk category. And since his PSA is less than 10 and his biopsy showed a Gleason 6, this patient should be in the low risk category. So for the low risk category, we offer the patient all treatment option. This patient even can have a brachytherapy since his PSA, since his volume is less than 40 ml. So we recommend all treatment option, but we recommend active surveillance for this patient.
Well done. So that's the right way to put it, isn't it? And So one of your junior colleagues in the MDT is asking whether you need to do any more investigations, any more staging investigations. What will be your recommendation on that question?
Yeah, for NICE guideline, we don't recommend to do more no more investigation for this patient. Bone scan usually indicated for a grade group 3, or if the PSA is above a 20, or for possible kidney disease on the MRI scan, or the patient having symptoms suggestive of bone metastasis. So for this patient, I'm satisfied with the MRI and the biopsy.
All right, perfect. So you said that the recommendation will be all options, but leaning more towards active surveillance. So what do you mean by active surveillance in prostate cancer?
Active surveillance, it means that we detect a small focus of low-risk prostate cancer. Therefore, we defer the active treatment to avoid the toxicity of active or curative treatment for the patient, since the risk of progression is low. Our aim is curative, but we will defer the active treatment, and we have a predefined protocol for the active surveillance. And when the patient changes his mind at any point, or there is either radiological or a histological upgrading, then we may consider active treatment.
Okay, all right. So how does it differ from watchful waiting?
So watchful waiting, mainly it's advice for people with life expectancy less than 10 years, people who are not fit to have an active treatment, and our aim is palliative. So we observe the patient by PSA blood checking. There is no predefined protocol. And when the patient starts having symptoms, or there is a significant increase in the PSA, then the only option for these people is to start hormonal treatment, and the aim will be palliative rather than curative.
All right, perfect. Coming back to the active surveillance, do you know any good evidence to support the decision for active surveillance in this patient?
Yes, I am aware of the COLTS study. It's a Canadian study. It includes about 1,000 men, and with a follow-up of about 77 months. And the conclusion from that, that the cancer-specific survival on those patients after about 9 to 10 years, around 98%. And about 2/3 of the patient, they are still on the active surveillance protocol. Only 1/3 they require to go to the active treatment. And this 1/3, about 12% of them due to patient-related anxiety, and they change their mind. And the other 22% is mainly caused by upgrading of their prostate cancer.
All right. So how are you going to counsel this patient for active surveillance?
So I will explain to the patient the rationale behind the active surveillance, that it is to defer the active treatment until the prostate cancer showed some upgrading in the histologically, radiologically, or through the PSA. I'll explain the protocol of active surveillance according to the NICE guideline, which include having a PSA blood test every 4 months in the first year. We will have a digital rectal examination at least once in 12 months. And then to arrange for an MRI scan at 12 to 18 months for the patient. If everything is fine, then we'll continue the second year, which include PSA blood test every 6 months, and then DRE once a year. After 2 years, patient can be discharged to the local GP if there is a agreed plan for follow-up with the GP.
Okay, perfect. And you will involve the cancer specialist in your discussion as well, isn't it? So, and that was spot on. And that was the NICE active surveillance regime in 2019. You have mentioned all the points really well. So we have come to the end of the active surveillance. So my plan was to discuss all these things in this session, and then move towards more like the treatment options and metastatic in the next session. So I think we have covered almost everything regarding the initial parts and the active surveillance. I'm not sure, Mr. Dhanasekaran. So, from my side, I enjoyed this session very much because you have gone through everything in real depth, and you're very thorough about the numbers, and there are no concerns at all. It was a really excellent performance. I'm sure everyone listening to this recording will also agree with me.
Thank you. Thank you.
Do you have any questions?
Nothing especially, but I want just to ask about having the 2 reading of the PSA. I think this is a nice guideline.
Exactly. I think, exactly. That is spot on. And the examiners will like that. And you have to have 2 reading because this was slightly above his age-specific PSA range. So it was spot on to say that I will repeat the PSA. It might or might not affect our further biopsy decisions, but that's a guidance. So that's why we had to do repeat PSA. Because the controversy in that one is, even if you repeat the PSA and if you come back as normal, won't do a biopsy or an MRI scan? Definitely we will do an MRI scan because one PSA is always above, but because the recommendation is like that, for exam purposes, it is always better to say and stick to the guidelines.
I think if you see the EAU guidelines, I don't think I've referred the recent 2021, but the previous 2020, for example, it clearly states do not decide on prostate biopsy based on single increased PSA value.
Exactly.
Unless the PSA is enormous, like 15, 20 or double digit, something like that. If it's a marginal increase for the age specific level, do not decide on single increase in the PSA value. That's in the EAU guidelines.
Exactly.
Okay. Thank you very much.
Ahmad, I'm very happy the way by which we have started. We have plenty of time and you can only get better from now. Communication wise, your voice is clear, your pace by which you are placing the answer also, I'm quite happy. I'm sure Anish also will add some feedback in those aspects also. I have a clue in this. When I'm posting the YouTube link, when you're hearing your own presentations, switch on the closed captions option, which possibly you may know. Closed captions is the one where, for example, if you're in a desktop, you can, for example, like a Apple MacBook Pro, you can just press C, or in the YouTube itself, lower down, you can press the CC box. It will auto generate your words as captions. You may have used it for some videos, isn't it?
Yeah.
I have.
Once you start using this and see what the YouTube interprets, and that's a very one of the easiest way to train yourself in avoiding the unnecessary syllabus like and those kind of fillers. And
Yes.
sometimes we are so ignorant. I'm absolutely ignorant. I have that bad habit for many years. But as I start looking into my own closed captions, I started filtering those things. And also, for example, trust biopsy, some words we won't pronounce in a very legible manner. We will just rush through. Examiners will be fine, but that's a very nice tool which indirectly available for us. And so whenever you are doing your own presentations, try to use the closed captions. I will say this for other trainees also. That will be a very nice way. If the Google or the YouTube types exactly what you meant to say, that means your voice is clear. If it types in a wrong syllabus, that means you need to improve the vocation of that particular sentence. And if there is those fillers, you can work on it. It's something very simple, but you have plenty of time to work it on. That's why I told you.
Yeah, very interesting. I will definitely try. Thank you.
Yeah, I completely agree with it because if you listen to one of my initial recordings with Mr. Dhanasekaran, there's a lot of these syllables for me. So he mentioned to me to go through these closed captions, and I can, if you listen to the rest of the recordings towards the end, near to the exam, it is completely different. So I still listen back to my recordings, the first one and the last one, and I can definitely say that there is a lot of difference between the first and last one, just because I put that closed captions and trained myself on that part.
Yeah, definitely, I will do. Thank you very much.
Very good. We'll communicate by WhatsApp and decide how to continue this prostate cancer. Possibly, I think Thursday is a good day. Let's see whether it suits for you. Okay, Ahmad?
Yeah. So it will be on 6 a.m. as well.
Yeah, is it good for you?
Yeah, that's fine. I don't have a problem in wake up early.
Good.
Yeah,
Okay.
perfect.
Have a good rest of the day, guys.